Dr. Peggy Porter is a pathologist from the Fred Hutchinson Cancer Research Center. She is the director of the breast cancer research program at the Fred Hutchinson, and is also the principal investigator on the new SPORE grant that we just received that we just received at the Fred Hutchinson. And so she's a very busy woman, and we're really appreciative that she should come and orient us to the key questions of implementation science.
While she's setting up, let me just say thank you to Ben and to Eduardo for inviting me to open this session, and really thank you to all the staff at BHGI and at the University of Washington who put this together. It's really quite amazing to get a meeting like this done and to get my slides up. Okay. So, does it... So it's a little hard at this on the third day to say anything new, but I'll try to do that. And as Ben said, we're going to be talking and focusing this morning's sessions on implementation. And first, the problem, you all know this and you know this well. There are 1.2 million new cases of breast cancer worldwide, and the majority of deaths from breast cancer happen in low and middle resource countries. These are data that come from Globocan 2002 and look at the incidence mortality rates in the world and by continent, but importantly look at the ratio of mortality to incidence. And you can see when we compare more developed and less developed countries that the mortality to incidence ratio is double in almost double in less developed countries than it is in more developed countries. And if we look at the continents, you can see that in North America, the lowest mortality to incidence ratio, but in Africa, there's almost a 0.7 ratio. And this is really unacceptable. If every woman died of who got breast cancer died of breast cancer, that number would be 1, and this is 0.7. Really unacceptable. So we have challenges, and we've been talking about the challenges for the last 2 days, so these are just some of them. But first, I think to really have accurate data that can assess the incidence, assess the mortality, the stage of disease that women are coming in with, the biology of the disease that they have, and do this across country, across races, ethnicities, in urban settings, in rural settings, and really across economic groups. We really need to learn how to design effective strategies to reverse these high mortality rates in countries where it really is unacceptable. And as we talked very much yesterday about, to make effective policy decisions that improve outcomes overall. And that includes mortality, it includes time to recurrence, includes quality of life, and includes survivorship issues. So as we sort of look at implementation and think about it, I can use the analogy of a bridge that we're trying to build, and one hopes that people really have the intent to build the bridge and not just a ramp for people to jump off of. But but we can say that the foundation of that bridge starts out to be something like vaccines, drugs, prevention of disease. And we have those in a foundation, but if we looked at some diseases, we would say that 14,000 people in sub-Saharan Africa and Asia still die daily from AIDS, from malaria, and diarrhea, all of which have those proven vaccines, drugs, or prevention, and we still have people unable to cross a bridge, still drowning in that water. So to look at this another way, to go back and look at what we think of when we think of translating these innovations, those stages of translation, we do have basic discovery and using that for health application or proving that it has health application. And I would say that in the United States and in Europe and in developed countries, we spend a lot of time right here. And this is what we call translational medicine. If you can say that there is a drug, that there is a biomarker, that there is a vaccine that you have discovered, and you can show that that will have some effect in a human population, that's where we spend a lot of our time and a lot of our money. We also do some of this, but probably not quite enough, is looking at best practices. So taking in the ideal situation, can we then say that those basic discoveries can be applied and get evidence for that? What we don't do as much, and what is, or we do, but we don't think about it as much, and what is very important in the global world, as we've talked about, is implementing this. So taking this all the way through these stages of translation to implementing it in multiple settings. And I would say, and I think Larry Shulman said this yesterday about this being an iterative process. This has to keep going back and forth to implement, to find out what works and what doesn't work, and then go back to get more evidence in best practice situations. You could also say I could put arrows in an iterative way going all the way back to basic discovery. If you implement and you find, as someone mentioned, that you really need a heat-stable drug, if you're going to implement it in a country that's hot all the time, then you'd have to go back to basic discovery to do that. So I just, let's say, how are we doing? We know that mortality from breast cancer is decreasing in the United States. So can we say, have we met the challenge that we want to meet in the United States even? So we decrease mortality. And just in answering that question, let me go to some of the how we might have decreased mortality and what the thinking about that is. And this figure comes from a paper that did a modeling analysis of two strategies for decreasing mortality, both mammography, screening mammography, and adjuvant therapy. And you can see, let me see if this works. You can see on the, yeah, it does work. You can see on this panel that as we go from, I think it's 1985 to 2000, that the green here, which is annual screening, has increased. Every 2-year screening has increased over that time. Irregular screening has increased. And we've gone from having women who were never screened, being about 75% of the U.S. Relevant population, to being more like around 20% who have never been screened. So we implemented this. We've also implemented and refined adjuvant therapy, chemotherapy here in the red line, tamoxifen therapy alone here, and seeing that we're giving these therapies more and more over time from 1970 to 2000. So we have implemented these two. And then part of this analysis was to look to see what effect those have had. And so this is just models that were used. The black line here is the actual U.S. rate of mortality, and you can see that it's decreasing here. Taking one of these sites and then modeling if there had been no screening or adjuvant therapy, this would be from 1979 to 2000. You can see that we would have predicted that the rate of mortality would have continued to rise. It would have been about even with screening only or adjuvant therapy alone. And when you add them together, the effects of the two together, screening and adjuvant therapy, this curve matches very closely to what the actual U.S. rate of mortality is. So the idea is that we have effectively decreased mortality in the United States with a couple of modalities by implementing them. But I would go back to say that we haven't really implemented them completely. When you look here at the disparities in the mortality to incidence rates by race, you can see that for whites, the mortality to incident ratio is around 2. For African Americans, it's 3. It's much higher than that. So we, again, have not been able to take these modalities in one setting and take it to another setting. We can go back and look at this graph and say, well, does that mean that African Americans are mostly in this group of unscreened? Are they not getting these therapies? Or you could say, we don't even have the data to say what it is. It might be something completely different that's creating that disparity. So this is one of the ways to look at this and then to ask the questions, which Ben did ask me to get these key implementation questions in.